Thank you for that introduction, Sue. Just to say what Sue said at the beginning, what I'll be talking to today within the next 15 minutes, and again, like Anna, it's a big ask, but I'm going to do my best to give you some of the main points for us to, start to debate the issue. I'm talking about the examination following birth. I'm not talking about the examination that's taken within 72 hours, which is the night included. I'm talking for that first hour following birth. And we need to make sure that we put it into the context of why we're doing it. We're doing it to identify any problems that the baby may have for adapting to postnatal life, to identify whether that baby requires any support to adapt to this postnatal life, because there's huge changes from in utero to postnatal life, to identify any trauma, and not only identify, but take action. What do we do if we find a problem? How do we minimize that problem while we either continue or stop the examination and ask for support? To assess the overall well-being of the newborn, to make an action plan for immediate and follow-up care, and to consider what education do we need to do now and balance it with the fact that we're dealing with a woman who's just given birth and is very tired. We need to minimize what important things that we get across and leave the rest for postnatal. And also, it's all very well if the baby comes after our examination to be normal, but how do we share information that deviates from normal before we bring a doctor? We can't just find something wrong and bring a doctor into the room, because the woman hasn't got herself together to know what she's dealing with and what questions she might want to ask the professional. Before we start the examination, it's very important that we have the history. The history needs to be undertaken every time we go near a baby, even if just to find out why the baby is not feeding on the breast. We need to find out the history. And this goes with the first hour examination, specifically the labor and what we're dealing with when we're examining this baby. Vitally, and is said in NHS England, attain every report that we see, we need to give women the chance to get to know their newborn baby. We need to make sure within that after birth, we examine the baby at 1 minute, 5 minutes, and 10 minutes. After that, once we're dealing with a normal baby, we need to go forward and allow that baby to get to know his mother and for the mother to get to know her baby. And that means we are in the room with the mother. The new guidance from BAPAM is to minimize postnatal collapse, is that we're in the room, and we're in that room to observe. And I have to say, with any examination, we need to look and listen, because that will give us far more information than any stethoscope can. And what we're looking at, what are we looking at? We're looking to see how the baby's on the breast and how well it's sucking. By looking at that, we can actually tell that the baby's neurological system is functioning, because in order to suck, swallow, and breathe, we need to have our brain active and the 12 cranial nerves are functioning. So I've got a huge amount of information just watching that baby feed. We also need to encourage skin to skin. And if the woman is willing and is consent to have that done, and remember, in some cultures, that may not be something the woman may want to have. So we need to make sure that while the baby is having skin to skin, it is safe skin to skin, that the chin is away from the chest and is kept warm. And we're there to minimize any harm that may come from that. And we're supporting the ongoing care with skin to skin. Now, this is the challenge. And I teach that when I'm going in the clinical area. We are so used, and I used to be one of those midwives, that I used to go ahead and examine the baby. And when it came to a sensitive area, like putting my finger in the baby's mouth, I would stop and look at the mother and say, you remember I said about putting my finger, are you still okay with me doing that? And remember when I wanted to do the genitalia, are you still okay with me? That means in taking my eyes away from the baby and looking at the mother or the father, I am taking my eye away a very important time. This is a baby. I have 2 clients in my care now, the mother and the baby. Before I start the examination, I would have explained the complete examination. And going back to what Anna said, informed consent isn't saying to the mother, do you want me to do this or do you not want me to do that? The mother can say yes or no, but that's not informed consent. Informed consent means she needs to know, why do I need to put my finger in that baby's mouth? Why do I need to use the spatula? That gives her the right to have the right information to make the choice. Otherwise, she's making it blind. And if something goes wrong later, she would turn around and say, but Stephanie, you never told me why you wanted to do it. I would have changed my mind and said something different. because those 10 minutes, 5-10 minutes need to be purely me and this baby. As you can see here, I need to make contact with this baby and observe it every second to give me the information. His behavior is his language, and I need that to make informed choices. I also need to know he's been through labor. She or he has been through labor. And labor that's normal is just as problematic. Birth is the worst journey we take in our lives. And it's important to recognize that and to treat this baby gently to reduce the stress and pain that this baby may be going through. Normal labor can be just as uncomfortable for the baby as instrumental labor. Allow the baby to lead the assessment. The baby will give you information as to when he wants you to stop and give him a chance to take himself together before you carry on. So he will show you signs like posseting, sneezing, crying. Crying is simple. To stop and give him time to go back again and complete the assessment. Then the top-to-toe examination starts, and I'm going to race through this, but please feel free to ask me any questions on any points that I raise, and I will be very happy to answer them at the end. It's important to recognize that I'm looking at the baby from head to toe to see that the baby's tone, skin color, and to look at the baby's mucous membranes to give me that. And I can validate that at the end if I needed to with a saturation. But at this point, just the color from head to toe will give me the... I needed to do the temperature. Now, if I'm doing a home environment, that's more a challenging temperature, but I would have made sure that the environment was warm enough. In the hospital, we're lucky to have the resuscitator. But taking the temperature and getting a reading isn't good enough. I need to know why I'm taking it and how real is it. For example, you see me here taking the temperature of this baby axilla, and the reading could say 36.5, but is it really 36.5? Because I also know from my theory that I've learned is the fact that brown fat is under the axilla. If the baby's temperature was 36, brown fat would be activated and my recording would be 36.5, but really the temperature of the baby is 36. How do I validate that probe? And that's by feeling the baby's extremity with his abdomen. Then we always start looking at the baby, and I always start next to look at the cardiorespiratory system. And this is the framework I use every time I assess the respiratory system. I count the respiratory system for a full minute, and then I look at nasal flaring, and then I look at grunting. If it's inspiratory grunting, that's grunting noise when the baby breathes in. I will not be inserting any spatula because there may be damage of blood vessels at the back of the throat that I may damage. But if it's expiratory grunting, it gives me the idea that the problem is lower airways and I'm dealing with either fluid or infection. Then I'm looking at symmetry of the chest movement. Now, you will not recognize, well, some of you may be very aware of this, but babies take a huge breath when they first come out because they have to move all that fluid out of the lungs and into the lymphatic system and get air into the lungs. In doing so, they can actually cause themselves to have a spontaneous pneumothorax. You don't want the baby to wait 8, 10 hours, 12 hours later when you send this baby to the postnatal, and you can go sleeping next to his mother as the mother's asleep. Nobody will realize that this baby's in trouble. This assessment will give you an indication of how the baby is to deal with it now, not 6 hours, 10 hours later. We need to look at the effort of breathing. Now, if I'm standing at the end of the table or resuscitator, I will not see the baby having a problem. But if you look at this slide here, you would see that this baby's got some sternal recession. I would only see it if I go to the side and give it eye level to see that this baby is having difficulties already at 1 hour following birth. Then the cardiac assessment. Well, we're not going to do a complete SEN examination, but we need to know which side is the heart so I know which side to put the stethoscope on. And then I need to listen and make sure I listen long enough to hear, is it sinus rhythm? What is the rate? Is it a normal rate? Is there any arrhythmias? That I need to take on board. Then I go up again to the morphological system because that's more uncomfortable with the baby because he's been through labor. So I need to take that into consideration and watch what I do with my hands and how firmly I press them against his vault to identify sutures and any trauma that the baby may have. Then I come down to the face. Now, I have to share with you, this week I've been informed by one of my midwives that she examined a baby that was 30 plus hours. And this baby was a Downs, and nobody had recognized that at birth, and the mother didn't have any idea of this happening. This is not the first time it's happened, and it's happened to me as well, that we don't review this baby to see whether his morphology is what we expect. And we do that by looking at the baby overall, Then we look at the baby's eyes. Are they appropriate position between the two of them? Is the two inner canthus the same as the inner and outer canthus of the baby's eyes? Then we also need to be thinking about, when I'm looking at the eyes, just to ask myself, is this baby got any secretions from the eyes that may be sexually transmitted diseases? And very importantly, has it got any conjunctival hemorrhages? If the baby has them at this time, not a problem at all. But if the baby doesn't have any conjunctival hemorrhages now, but has them on day 5, then I need to be thinking of safeguarding, because this baby doesn't have them if he hasn't been born with them. Perfectly normal to have them at birth, a huge problem if they happen later on in the postnatal period. Then I looked at the position of the ears. They're wonderful to give me a lot of information. They give me information on how the baby's ears have formed. Is it the appropriate gestation? A baby at 38 weeks, ultrasound is 2 weeks either way. So this baby could be 36 weeks, not 38 weeks. So I'm dealing with a late preterm. What is this baby, term or preterm? Then I need to think, can this baby have an external meatus so he can actually hear, or does he not have any? Then I'm going down and looking at the philtrum. Is the philtrum the appropriate size, or is it wide? Am I dealing with a baby that mother has utilized alcohol? Then I'm going down to the mouth. Now, I don't examine the mouth now. I leave it to the end of the examination because it's disturbing for the baby, and I want to complete the examination before going into the internal structures. All I look for now is whether the airway is clear and whether I'm dealing with a baby that may have, if he has got a lot of secretions. Did I look at the history properly? Was there polyhydramnios? Am I dealing with a baby with esophageal atresia? That's quite a major problem that I need to take forward. Then I come down to the baby's chin. I know that the chin keeps the airway clear. So if he has got a little one, small receding chin, I'm concerned how to manage this baby and need a second opinion. Then I come down to the baby's neck. Can he rotate it from side to side? Then I continue down to the arms. And then I noticed that the baby throughout the examination would have moved both arms. But then sometimes when the babies, and we hear from this, I'm not sure about you on the call, but how many of you have noticed that babies are being identified now? Maybe we're looking for it and identify it more now than we did before. But they are coming up with fractured clavicles. And the fractured clavicle is extremely painful for the baby. And we need to make sure how to manage it now to complete the examination, and how to minimize the pain for the baby, and how, with the baby strapped to his arm across his chest, can be breastfed, that we need to provide the continuous support for the mother. Vitally, we're not really the ones who are doing the first examination. I bet all of you know on this call, the first examination is by the mother. The moment you hand her a baby, she's gone through this baby with a fine tooth comb. She knows exactly what's right and what's wrong with her baby. We need to take the time before we start the examination and say to the mother, is there anything you'd like me to focus my attention on? Try not to use the words abnormality. As Anna said, language is very important to enable the mother to be free to tell you what the problem is. If you just say, what part would you like me to focus to look at, rather than say, is there anything that you think is not right for this baby? Then that will make her in a difficult position. She might not share with you what she's worried about. Now, we know that probably we'll count the fingers anyway, even though the mother has. We make sure there's nails at the end of them, because you'd be surprised how one nail missing, it may not be picked up by a practitioner, and that can indicate syndromes in your baby. But vitally is the grasp. The baby can move, like this baby's moving his arms, but he cannot grasp. It means that it's got a nerve damage. We need to sort that out sooner the better. Then I come down to the abdomen, which is one of my pet ones that I would like to discuss even more, but I haven't got the time. We look at the abdomen that is rounded and there is invisible peristalsis, but the cord. The cord needs to be left quite long, as you could see here. The longer, the better. And then when it comes to this examination, I can put the baby under the lights and view this cord to see that there is no secretions coming from. But vitally, I know in embryology, the abdominal contents, the intestines, develop outside and then go back into the abdominal cavity. Maybe a bit, the major ones you could actually see, but a tiny bit of intestine in the cord needs to be viewed and excluded before you go ahead and cut through it. Because now I've got the chance and I can leave it long and get for a second opinion, or if it's okay, I will cut it to the right length, because the baby doesn't need to have this length of cord attached to it. The groins reviewed, especially on crying, because if the baby's crying like this, it's a good time to look at them, because you may notice a hernia then. Speaking to experts on consultants on ambiguous genitalia, it's important to recognize we need to not validate the sex until we have actually looked at the baby and at this point, and then say you've got a male or a female. And to validate the sex of a male, you need to make sure you look at the genitalia for gestation and also look to see that the baby hasn't got a hypospadias. You'd be surprised how many hypospadias have been missed. We need to really look that the external meatus is where it should be. We are looking at the testes where they're descended, but this is an emergency. And I'm aware of one hospital that had 3 in 1 month. Testicular torsion should not wait for the main examination later on. This is a medical emergency and needs to be picked up now. What are their scrotum? Is it equal? Is it discolored? Hydrocele is normal, but the mother would get worried. So we need to explain that to her and what it means. For the female, it's just as important to review the male genitalia to validate sex. We need to make sure that we can actually separate the labia majora from the labia minora. Just looking externally does not give you an indication. Then we need to make sure that we see that the hymen is patent. Now, you may say, why are you worried about that? Well, it's not a problem to a baby now, but when she starts to menstruate later on, she can't. And there will be huge problems, which I haven't got time to go into now. But we need to validate because the hymen is quite low at this time and is visible to us to be able to view. So if there's no secretions, we need to visualize that it is patent. This is important, the perineum size at this hour exam. If the perineum is short, it is vital that we pick this up now because this baby will have to go as a medical emergency because the earlier the treatment starts, the better the management in the long term to avoid later on uterine infections. The spine, most of you on this call would be like me. I was taught to just hold the baby up, run my finger down and check the spine. Now I know I will have to lift the baby up to see that the baby's spine is straight, but immediately I put the baby down because this is not only uncomfortable, but dangerous position to examine the spine. And in examining the spine, I need to make sure it's intact. There's no dimples, and if they are, how far away from the anus is. This is the important part, the anal wink. I can't tell you. In the past, I was taught, and maybe some of you are at the same time as me, to put thermometers in the baby's rectum to look at the temperature. Now, you'd be aghast at this, but this is what we did years ago. We're no longer doing that, but we need to make sure that the anus is patent, and that's really looking at it while it's prone properly and make sure that there is an anal wink. This is the time to look at the buttocks for any fat that isn't present. So you expect the baby to have adipose tissue. That's what maintains his glucose. So a baby that's small for dates and it comes less than the 2.5, I have a number to work with, great. A baby that's light for dates can be 3 kilos, but I need to look at the baby closely to see how much adipose tissue it has, and I need to compare it with the head circumference, and a 2 centile difference would alert me to the fact that I've got a baby that I need to manage with the senior neonatologist to prevent hypoglycemia and other issues. This is the other one. We concentrate on breastfeeding, but we need to concentrate just as much, if not more problems can occur with artificial feeding, especially at this first feed. No baby can be given an artificial feed until we examine the internal structures of the mouth. We first do a digital examination, and the advice is to put a spatula in and view to make sure we haven't missed the cleft palate. Now, in this picture, you see a spatula going in and for us to view. Now, this spatula is held in this position in order for us to see the cleft, but in actual fact, our finger should be at the end of the spatula. What has happened recently, and I've heard there might be new guidelines coming out, the baby's tongue, for those of you who have done this, is very strong and can lift it up and split the spatula and cause splinters to go off into the baby. So it's important to put it in a glove, in a finger in a glove before we examine. The other thing before we actually talk to the full examination, we need to make sure that the baby hasn't got respiratory distress. A baby that is trying to breathe rapidly and also swallow, it's not going to do it. I can't do it, nor can the baby. So has it got any, exclude that. And then make sure we're there to give the first feed. We're there for the first breastfeed. We must be there for the first artificial feed because I can tell signs for atresia, but tracheoesophageal fistula, I can only manage it to see it when I'm giving the 15 mils at the first feed with this baby. So be there when that first feed. And in conclusion, when I finish the examination, I then shut away all the noise, all the people around me, and then go through mentally the top to toe assessment. Have I done everything? Have I forgotten something? If I have, not the end of the world. Do I go back and do it now, or do I do it later? It's nothing worse than dressing the baby and then recognizing you haven't done something. What actually is my action plan? And if I found a deviation, do I need a second opinion, and from whom? How do I share the information with a woman? And this is important. The language we use and how we share this is vital. It's important to give the correct weight, the information to the woman, so you don't terrify her, but you balance the information. And she knows that a doctor's coming in for a second opinion to help us continually support the baby. And for her to know lots of conditions can be treated beautifully today without any problem. But what I also recognize, bombarding her with education is not the right time. The birth time is the last time. It's the least time you're going to be giving. You just give her the minimal amount of information because she is trying to accomplish and stay compos mentis after a long labor. Even a short labor is enough trauma for that woman. And as you can see, Winnicott, who's a major psychologist, has actually done research that the women has said we are dominant, we are not very nice, we are precursory. We need to take that into consideration when we are sharing information and how we are dealing with the woman. Ask about how she is before we start talking to the baby. Thank you for listening, and I've managed to do, I've gone over the time again, sorry. Please put your questions and comments on the chat. Thanks very much.